Okay. In general, why is minimally manipulated, specifically cytologically and architecturally preserved cancellous autograft, considered the true gold standard over all other bone graft options?
Well, I think the answer to that question is that you're trying to optimize both the architecture and the viability of the mesenchymal stem cells within the graft itself. And without distorting the architecture and by minimal manipulation, you're less likely to devitalize the cells within the bone graft and thus optimize the bone graft. We know that cancellous bone, which has a particular architecture, has a much better capacity for incorporating by initial revascularization within the host bed. In fact, you can demonstrate revascularization within 48 hours in the host tissue or the host site in a purely cancellous graft, whereas dense cortical bone or bone that's been morselized or distorted has less capacity for being revascularized. And of course, the cellular elements within, if they're not properly preserved, which would be a short period of time from the time of harvest to the time of implantation and avoidance of desiccation, those cells are less likely to function as osteoblasts if you don't preserve them.
How does the COREX preserve this innate graft architecture?
Well, the primary method of architectural preservation is by utilizing a trephine-like mechanism or a trephine mechanism, which essentially cores around the perimeter of the bone graft material. And other than for some slight compaction, which occurs naturally with the insertion of the trephine and the capture mechanism, the architecture is not distorted at all. And the cellular elements are not dissociated from their native location through any kind of suction or irrigation process.
Awesome. Why is cytologically and architecturally preserved cancellous autograft superior to BMP for most clinical indications?
So as far as BMP2 is concerned, while it's a rather prolific bone stimulator, it also is a fairly prolific bone resorbing influence. So it is a dual function, if you will. And the initial function of inflammatory production, which includes resorption of the bone, is counterproductive when you're trying to essentially produce bone without compromising the integrity of the host site bone, as would be the case in a number of instances where you're putting an implant in. If you're introducing BMP2 and you have an implant and you resorb around the implant, there's a greater chance for a movement or displacement from the intended position. In addition, BMP2 can produce an inflammatory action in adjacent soft tissue. This was dramatically illustrated in the cervical spine, where it eventually acquired a black box label or warning label prohibiting its use in the neck without the potential for serious or even life-threatening inflammation or swelling. Nerves can be irritated by BMP2, so neuritis is associated with placing BMP2 in close proximity to nerves. And then there's also the risk of heterotopic bone. So all of these, bone resorption, the consequent osteolysis and implant migration and the neuritis are not found with autologous cancellous bone. So those are some of the advantages. And in a number of studies, there's no significant difference long-term in terms of the amount of bone and a successful fusion between BMP2 and autologous cancellous bone. So you're inviting these risks, if you will, associated with BMP2 that are not necessary if you just use autologous cancellous bone. You're going to get the same healing level, even though it might be more exuberant initially. Ultimately, the healing response will be the same.
Gotcha. So why is minimally manipulated cancellous autograft superior to synthetics for most clinical indications?
Well, because it's a combination of osteoinductive, osteoconductive, and osteoproliferative. And the synthetics may have some osteoinductive capacity. They're not particularly osteoconductive, and they're not osteoproliferative. So it's just a matter of having all of the available qualities for bone production in autologous cancellous bone, which is not available in the synthetics.
Why is minimally manipulated cancellous autograft superior to DBM for most clinical indications?
So DBM is primarily a osteoinductive element. It's not an osteoconductive element, and it's not an osteoproliferative element. So, all of these bone graft alternatives can work. It's not that they can't work. They can work. It's just optimization, which is your question. And they don't optimize the conditions for healing as much or as well as autologous cancellous bone.
Why is minimally manipulated cancellous bone superior to allograft for most clinical indications?
So allograft is treated in usually with freeze-dried or lyophilized to reduce its immunogenicity. But even with treatment, it is still immunogenic. It's not immuno privileged tissue, and so one of the drawbacks is that you get an immunologic response, a cell-based immunologic response. The other problem is, and I don't want to overstate it, but again, there's no osteoproliferation associated with just allograft, cancellous allograft. That's more of an osteoconductive bone graft material, and not as much osteoinductive as DBM.
Gotcha. Why is minimally manipulated cancellous autograft superior to BMA or PRP for most clinical indications?
So bone marrow aspirate and platelet-derived growth. Sorry, I'm having a mental gap here. Platelet-derived growth factors are just not conclusively demonstrated to be good bone-inducing agents. And there have been some studies that suggest they have some bone proliferative capability, and others that have shown no beneficial effect. So I wouldn't want to invest the effort and the patient risks associated with a major procedure and use an inferior bone grafting material like bone marrow aspirate or platelet-derived growth factors.
Why is minimally manipulated cancellous bone superior to cellular-based matrices for most clinical indications? You're going to love this one.
So cellular-based bone matrices were intended to have all of the properties of osteoinduction, osteoconduction, and osteoproliferation. That was the intent. Unfortunately, these composites do have immunologic properties, both cellular and humoral in nature. There's a misconception, and it's misrepresented, has been misrepresented for quite some period of time, that this is immunologically privileged tissue. But that is not the case. A number of studies have shown that only in vitro, not in vivo, only in vitro is there immunoblunting with the cell-based response. But in vivo, there's both a cell-based response and a humoral-based response in terms of immunologic sensitivity. And perhaps even more obvious is that mesenchymal stem cells don't produce any bone. They are a progenitor of cells that ultimately produce bone. And that is osteoblasts and osteoclasts in combination, and chondroblasts are used as the precursors to bone formation. And mesenchymal stem cells do not have osteoclasts, osteoblasts, or chondroblasts within them. They have to differentiate. And this whole idea, again, as I indicated previously, that the tissue is immunologically privileged is, again, sort of a false narrative, because not only do mesenchymal stem cells elicit humoral and cellular response, but if they were to differentiate, if they were to survive long enough to differentiate into osteoclasts and osteoblasts and chondroblasts, they would immediately be targeted by host immune response. And I guess the proof is in the pudding. There's been 3 systematic review studies that have been published in the literature on the use of these cell-based matrices. And all of them, all 3, conclude there's no evidence that they're effective, period. And in some studies where cell-based matrices are used with a carrier of cancellous allograft and DBM in athymic rats or mice, there's an actual detrimental effect by adding these mesenchymal stem cells. So it's a very expensive composite graft, which had a theoretical appeal, but it's never realized in a clinical setting. And there's some false premises associated with its promotion.
Why is minimally manipulated cancellous bone superior to local autograft for most clinical indications?
Yeah, so this problem has to do with the type of local autograft. If you could harvest minimally manipulated cancellous bone without separating the endogenous cells within the trabeculae, then it would be the same thing as autograft from a distant site. The problem is that generally is not what happens. Generally what happens is surgeons are taking fragments of cortical bone, fibrous tissue, periosteum, tendinous and ligamentous attachments, and they're harvesting them with their bone, basically a kind of a bone resecting instrument, like a bone drill or something like that. And a few things happen. You can't separate all these different tissues within the slurry that you're going to get. In addition, that slurry could be heated up with the tip of the drill, killing all the cells within. And there's no way that one would anticipate that the cells would behave the same when they are disturbed from their normal architecture. Cells are very much influenced by their immediate surroundings and the way they behave. So local cancellous bone, whether it be harvested with a rondure or a bone drill or any of a variety of other techniques, is unlikely to be pure cancellous bone. It's unlikely to have the cellular elements preserved in their native location, and therefore it's going to be less likely to be effective than harvesting cancellous bone in a minimally manipulated manner from a distant site.
Gotcha. How's everything? Did you want to take a break or anything? You're good?
No,
Okay.
I want a trick question.
We'll eventually run into one. Of the following forms of gold standard cancellous autograft, which option is considered the highest grade in terms of bone healing potential, and why? So choice A, morselized, let's say through power drilling. Choice B, desiccated via suction. And choice C, minimally manipulated, non-morselized, non-desiccated cancellous bone. So they're all cancellous bone, but one's morselized, others desiccated, and the third is just...
I think the principle remains the same. There were studies done on morselizing cancellous bone that showed a delayed healing effect. And similarly, these are in animals. Similarly, in Scandinavia, a number of years ago, they looked at if you desiccated cancellous bone and placed it in a host site, what happened. And again, with desiccation or morselizing, the bone is less apt to produce, the harvested and transferred bone is less apt to produce a healing response than if it's minimally manipulated and or desiccated. So the answer is obviously the less you do to the harvested cancellous bone, the better. The less you compress it, the less you morselize it, the less you desiccate it, the less you alter the cellular elements, positions within, the better. I mean, that's the general principle.
And how do these suction devices desiccate the bone?
Well, I don't know if desiccate's the right term, because it's more that they suck the mesenchymal stem cells away from their native location and replace it with blood. You know, the bone is, it's not that the bone dries out, but it basically gets replaced with blood and a clot. And just adding the cells back later does not place them in their original position. And there's a certain amount of injury and probably necrosis that occurs with that process. So I've never seen a good study, but I'm highly suspicious that if you looked at the recovered cells in these reassociated cancellous bone graft proposals or methodologies, you will find that there's damage to the cells, and you're going to find that they're no longer in their native location.
Of the following ways of obtaining gold standard cancellous autograft, which option generates the lowest donor site morbidity? You know, in terms of blood loss, infection.
Yeah, so I mean, obviously, minimally invasive techniques that stay within the confines of the cortical bone afford the lowest risk for infection or harm to adjacent soft tissue. So any kind of harvest that involves stripping soft tissue off the bone, larger incision than is absolutely necessary to access the bone, is more likely to produce a variety of complications, including persistent donor site pain and infection. And also, a harvesting methodology that involves a clear proprioceptive appreciation for the instrument's action at its tip, at its cutting tip, I believe is very valuable, because you're going to run up against cortical bone in any axis eventually with a deep enough insertion. And if you're using a power instrument, perceiving that limit, which you want to limit yourself to, will be less apt to be noted. So I think a hand-operated, minimally invasive tree find affords the most or the least likely to produce a subsequent donor site complication.
How do power suction devices generate donor site morbidity?
Well, a combination of things. Again, when you're using a suction device, obviously you're placing negative pressure on the bone trabeculae, and that's more likely to cause bleeding, unnecessary bleeding. In addition, if you exit the bone, that suction is going to pull soft tissue into the aperture of the coring or cutting device. And a power instrument in general, although it can be convenient, does not afford you the same tactile and proprioceptive benefits that you get from a handheld device.
Gotcha. Let's see. Of the following methods of obtaining gold standard cancellous autograft, which option requires the fewest time-consuming surgical steps in terms of setup, disassembly, cleanup, etc.? Choice A, power drilling. Choice B, power suction systems. Choice C, traditional open harvesting. And choice D, percutaneous harvesting with an all-in-one device.
Well, I'm going to say this. In most instances, in terms of time efficiency, which is a consideration, the all-in-one device will save time because you're not having to use a drill to penetrate the cortex. Now, we're not going to exclusively consider the time consideration. Safety factor is another thing. I mean, if you have a drill, you can, if you're not careful, plunge it deeper than optimal. And the COREX device has a depth stop, which prevents you from plunging if you pay any attention to the resistance you're experiencing during the rotation of the trocar tip against the cortical wall. So, I mean, I think you're going to find that, obviously we know that open harvesting with the use of osteotomes and or gouges can take far more time than just using a percutaneous technique. So the answer is the percutaneous all-in-one device will generally be the most time efficient and I think safest and least likely to produce morbidity.
Gotcha. Of the following types of cancellous autografting systems, which option requires the fewest accessory instruments or devices, such as, power, fluoroscopy, retractors, osteotomes, guide wires, rongeurs, etc., and why? So choice A, power drill system. Choice B, suction device. Choice C, a reusable manual tree find system. Choice D, a single-use vacuum-sealed, all-in-one percutaneous harvesting device.
Yeah, I think some of the responses I've given previously cover this, but the benefit of using a single patient use sterile device is considerable when you think about all of the kinds of processings that need to take place in packaging and placement in a sterile tray, etc. Now, the other advantage is that we know that the trocar tip is new and sharp with each use. We know that the tree fine, which has some small castellations for microfracturing the cancellous bone, is also going to be new and fresh. So there's some real reasons to consider and opt for a single patient use previously sterilized package device.
Gotcha. Of the following bone grafts, which is the least expensive option over time and why? So many choices here. So BMP, cellular-based matrices, BMA, allograft, synthetics, DBM, local bone, reusable power drill systems, a power suction system, and a single-use vacuum-sealed all-in-one percutaneous harvesting device.
So, I mean, your question was, which is the least expensive? Well, if you're going to consider expense, you have to consider effectiveness as well, because if it's ineffective, that means a reoperation for, for bone repair and anything that is less likely to be effective would be something I would exclude from consideration. And I think, based on just the literature and the abundance of available peer-reviewed journal articles that are not written by potentially conflicted authors, autologous cancellous bone is the most effective form of bone grafting. BMP2 is certainly effective, but as we mentioned before, it has a number of associated unique complications that I think should be considered and avoided. And I indicated previously that cell-based matrices have not been shown to be effective. So I would definitely exclude those, as well as the lack of clear evidence to show the benefit of bone marrow aspirate or platelet-derived growth factors in producing bone. So you're left with basically autograft, and there are different ways of harvesting autograft. Obviously, percutaneous is something I would favor. The thought is, if you use a reusable device, that might be a little less costly than a single patient use sterile device. But there's some benefits that would offset the cost. But that would be my response to your question.
Gotcha. How does the COREX enable auditory and tactile feedback during harvesting?
Well, because it's a manual instrument, the surgeon can actually feel the effect, if you will, of the end of the operative end of the instrument in their hand. As they are rotating and advancing it in the cancellous bone, they can feel the microfracturing, which is experienced both in a palpable as well as an auditory manner, and or a tactile and auditory manner. And you can actually hear that little kind of crunching, if you will, almost like Rice Krispies as you're going through the cancellous bone. And you can feel the castellations at the end of the trephine fracturing through, microfracturing the architecture of the cancellous bone around the perimeter of the harvested bone. So that's how that is beneficial to the surgeon.
How does the COREX mitigate the use of fluoro, or even eliminate the use of fluoro?
Well, almost. I mean, I can't really think of one potential harvest site that isn't subcutaneous. All these harvest sites are subcutaneous structures. So once you incise the skin, you really have a minimum of subcutaneous fat and then periosteum and bone. So finding, as long as you know the anatomy, finding the bone and where you want to enter shouldn't be hard. With just a little bit of anatomical understanding and experience, it should be very, very straightforward. And then once you've entered after you've created the cortical window with the trocar tip, the trephine is designed not to penetrate cortical bone readily. Obviously, if you're using it improperly with excess of force or a mallet, things that we recommend highly against, you can go through cortical bone, particularly if it's very thin. But if you just use it manually with a rotation and just a slight advancing pressure, you can stay within the confines of the cortex and determine that you remain within the confines of the cortex very, I'll say, easily and very perceptibly. So that's the reason why you don't need to use a C-arm or a fluoroscopy to visualize the instrument, because you know how to enter the bone. You have a general sense for its anatomy, and the COREX device itself facilitates your understanding where the tip is within the anatomy. There's also a beveled angle on the end of the tip to help facilitate staying between the planes of cortical bone, as can occur in the pelvis.
Wonderful. Let's see. Of the following cancellous autografting systems, which option mitigates the likelihood of cortex collapse during the cortical window creation, and why? So choice A, a power drill system. Choice B is the generic tree fine system. And choice C, COREX.
Yeah, I'm not quite sure what you mean by cortical collapse, to be honest with you here. I'm not quite sure. But, the value of the trocar tip on the COREX
The
device,
cortex, basically.
the value of the trocar tip on the COREX device is that it has a shoulder stop.
Mm-hmm.
And it's advanced. It is a very sharp instrument, and it's advanced primarily through rotation, not through forward pressure. So the way one can determine that you've reached the shoulder stop is when there's no longer any resistance to rotation, not to forward advancement. The forward advancement is stopped by the shoulder stop, and the rotation resistance ends as soon as you've completed the full penetration of the trocar tip up to the shoulder stop. Whereas with a drill bit, you don't have a shoulder stop. It's easy to plunge. With using a standard trocar tip, it's not designed to go through cortical bone. So, I mean, you want to use a device which is intended to go through a cortical bone, but one which limits the depth of penetration, which the COREX device does.
Great. This kind of leads to the next question. Of the following cancellous autografting systems, which option can be used safely by nearly, I'll just say by most surgical subspecialties, such as spine, foot and ankle, musculoskeletal tumor, craniomaxillofacial surgery, etc. And on nearly, or I'll say on most cancellous bone repositories. So choice A would be a power drill system. Choice B would be a suction device. Choice C just be a generic tree fine system, and choice D, COREX.
And you want to know which of these can be used in a variety
of just anatomical harvesting sites, and on why and why. So for instance, I'll just say company A, they have a harvesting system, but it's generally recommended to only use it on the foot and ankle, not on the iliac crest. But with COREX,
so I don't really know. I mean, I haven't had enough personal experience with some of these curette-like tip devices to know why, but my guess is that the further you put the curette into certain anatomical structures, the less likely you're going to know where the tip is. It's just harder. A curette has to be sharp, and if you have a long lever arm, as you do with some of these devices, it doesn't take very much effort for the curette to go through the tables of the pelvis, because just a small change in your angle will impart an enormous leverage advantage that you'd have through the handle. So, I mean, I don't have any personal experience with it, but I'm just, anticipating or speculating that that would be a concern.
Gotcha. So, general question. How does the COREX achieve the goal of preserving the innate trabecular architecture and cellular orientation of its cancellous graft product while mitigating donor site morbidity, cost, accessory device requirements, and time-consuming surgical steps?
Well, the answer to that is really a compound answer. First of all, it's a single patient use, all sterile package device. That's the first part. Second part is it has all of the elements necessary to penetrate the cortex and then harvest the cancellous bone with a tree fine-like mechanism, which involves essentially coring out a cylinder of cancellous bone, which has the least amount of architectural distortion that I can sort of think of. And so I think that's kind of the general answer to your question. And it's a minimally invasive device, so you're doing it percutaneously. So there's a very small incision, virtually no subcutaneous soft tissue dissection involved. So you're less likely to get any kind of infection. And then because it's a manual device, you should be very much aware of where the tip is during the procedure, so you're less likely to violate the cortex in an unintended manner.
Great. Let's see. Using multiple passes from a single cortical window, how many cc's of cancellous dowels can the COREX harvest from I'll give you a number of sites, the ACES? Whoa.
Well, again, a lot of this depends on the patient's
Just like a range, what do you usually see?
Well, I think it's reasonable to expect that you can get somewhere between 15 and 20 cc's if you optimize the harvest effort.
What about the PCIS?
The posterior superior iliac spine, well, maybe a little more. Maybe it's more like 20 to 30. But again, it depends on the surgeon's skill and in optimizing the harvest from the crest. As the surgeon becomes more and more familiar with the instrument, they can get more and more bone safely out of the pelvis by redirecting it in many different axes.
What about the proximal tibia?
It's going to be on the order of around 15 cc's, something like that.
The distal tibia?
It'll be less, but I don't know. Maybe it's more like 10 cc's, but I can't tell you a specific number. Again, a large amount of this volume is dependent upon the bone density of the patient and the skill of the surgeon in using the instrument for harvesting.
Yeah, there's definitely
but for most applications, unless you're doing a 3 or 4 level lumbar fusion, you're going to get enough bone from the customary harvest sites to suit your needs. And if you need to supplement with lyophilized or freeze-dried cancellous bone, that's an inexpensive option that one could utilize.
Last one, the calcaneus.
There is going to be less, is probably going to be somewhere between 5 and 10 cc's.
That's more than enough for most foot and ankle procedures.
Plenty for most foot and ankles.
Yeah. Why is the proximal tibia such an ideal yet underutilized harvesting site?
A combination of things. Traditionally, the iliac crest has been a highly utilized site for open harvesting in both anterior and posterior approaches, supine and prone patients. And so there just hasn't been as much clinical experience with the proximal tibia. Although there's plenty, there's just not as much. And a lot of surgeons were trained to harvest bone from the iliac crest, and not as many from the proximal tibia. Also, I think there are surgeons who are not orthopedists who are harvesting bone, and they may be less comfortable with using a harvester around the knee for fear that it might cause some injury that they would be unaware of or unable to address. And the reality is, it's an extremely safe location, and you're not going to enter the knee joint because first, it's easy to palpate the joint line and to stay well below it. Second, the subchondral plate is very dense, and if you're using a manual device like the COREX device, even if you were to misdirect it up toward the uh, tibial plateau, you would feel the subchondral plate immediately, and you would just stop advancing the instrument. The nice part is a medial approach in the proximal tibia. And again, I want to emphasize that you want to enter the proximal tibia medial to the tibial tubercle in its upper third. If you get too distal, you end up in more of the diaphysis of the tibia, and there's less cancellous bone to be had. So that's a mistake you don't want to make. You want to stay in the upper third of the at the level of the upper third of the tibial tubercle and about a finger breadth medial. This is a very, very easy location to palpate. There's no significant neurovascular structures there. It's a common location for drilling for anterior cruciate ligament replacement procedures, and there's essentially little or no literature to describe complications from drilling in that location for anterior cruciate ligament replacement procedures. So I think the primary reason it's not used is just lack of familiarity. Surgeons just aren't familiar with it. But I highly recommend it because it's super easy on a supine patient, and I think it's more reliable than the anterior crest for harvesting.
Gotcha. Let's see. Why has autologous cancellous bone recently fallen out of favor for biologics over the last 15, 20 years? And how can the COREX bring surgeons back to the gold standard?
Well, I think the primary answer to that question is effective marketing. The primary reason why surgeons have been reluctant to harvest bone is due to a proliferation of marketing material that cites very dated literature on complications of autologous cancellous bone harvesting. And in fact, there was an article that was published in the Spine Journal on the pseudo-morbidity of autologous cancellous bone harvesting. And the idea that you have 25, 30, 40% long-term serious complications from harvesting cancellous bone is really an exaggerated statement of fact. Why I say an exaggerated statement of fact is because, sure, you can find some literature, dated literature, that might come up with that statistic, but that involved very old techniques which were not percutaneous, which were maximally invasive, and associated with soft tissue stripping, use of osteotomes, and the more recent techniques that involve minimally invasive approaches to harvesting bone produce trivial levels of complication, trivial levels to negligible levels. And one can find fairly good justification for making that statement if you just look at the BMP2 studies that were used originally to gain approval from the FDA. There were 3 multi-center studies that involved autologous cancellous bone and BMP2. And if the patients received autologous cancellous bone or BMP2, they had essentially the same functional and symptomatic level at the time of healing, 6 months and beyond. And if harvesting cancellous bone, and that was an era when minimally invasive harvesting was not necessarily as prevalent, if it was so morbid, why wouldn't the patients who had BMP2 have much lower symptomatic levels than the ones who had received autologous cancellous bone? And Chris Bono and Eugene Caragi and one other author in this pseudo-morbidity commentary in the Spine Journal pointed this out. So again, I think it's just extremely effective marketing campaigns, and then a lack of training for some of the more recent surgeons who have not been taught how to harvest cancellous bone in a minimally invasive manner. And perhaps also, to some extent, a lack of desire to make the effort to harvest the bone, because it's easier to just open a bottle than it is to, or a package than it is to harvest cancellous bone. Although you do get paid for it, and it isn't a fairly short and short-term effort, and has a very rewarding outcome when you see the beautiful cancellous bone that you're able to obtain in a minimally invasive manner.
Gotcha. Describe the typical or anecdotal feedback you've received from COREX users and their patients.
Well, the typical response is that there's essentially no pain at the harvest site after the first week. And even in the first week, it's trivial. And that's very nice. It's what we expect, and it's what we hope to hear, but that's been confirmed many, many times by many surgeons.
And this is from all harvesting sites, including
Yeah. There's no harvest site that I'm aware of that's particularly painful post-operatively. So
Why
that's
would
the main advantage.
Wow. Amazing. Why would the COREX be an ideal biopsy tool for orthopedic oncologists, spine surgeons, foot and ankle surgeons, or trauma surgeons?
Well, I think that I would say it's, if the anatomy is appropriate, it's more likely to yield a diagnosis, because you're going to get more likely to get intact tissue from the intraosseous location because of the capture mechanism. We have a patented capture mechanism that is more likely to capture the pathology within it than using a Craig needle or a Jamshidi needle or some other types of bone biopsying instruments. Usually they're much smaller diameters, and they're less reliable in capturing the bone and the pathology within the bone.
Let's see. How long does harvesting with the COREX typically take?
Well, in experienced hands, I'm not saying that you have to be some kind of gifted surgeon, but in experienced surgical hands, somewhere between, I'll just say 5 and 10 minutes, maybe 15 minutes, if you're doing multiple passes and have to harvest a lot of bone. 5 to 10 minutes. It's not very long.
Gotcha.
It takes longer to sew the wound than it does to harvest the bone. I mean, if you're meticulous about sewing, it can take longer to stitch up the wound than it is to harvest the bone.
Gotcha. What can you backfill the harvesting site with?
Well, I think that you can use a variety of materials, but probably the least expensive and the thing that makes the most sense would be cancellous allograft. Freeze-dried cancellous allograft. It's the least expensive. It's going to be more rapidly incorporated, and it's easier to pack than some other materials.
What about gel foam with a little marcaine?
Well, that's not for packing the cavity or backfilling. There's a difference here. Backfilling is when you're trying to fill in the cavity you've created with the harvest. If you're just trying to reduce bleeding and mitigate some local pain, a little marcaine on gel foam just poked into the hole is all you need. But for backfilling, I would use cancellous allograft.
So better question then. Does the COREX typically require backfilling?
So it's just like any harvesting device. If you look at the literature, there is statistical evidence that the void created by harvesting cancellous bone will not be replaced with new bone following. And, kind of depending upon which anatomical site you're looking at and which study you're looking at, it can range anywhere from, around 20% to 50% of the time it will not refill. But because it doesn't refill doesn't mean that there's going to be any problem. So if you look at the calcaneus, I think it's somewhere in the neighborhood of around 20% of the time. It will not refill with cancellous bone or reconstitute. But we don't see calcaneal fractures prevalent after bone harvesting. So it has to do with the location of the harvest and how important the trabecula are for the integrity of the bone. But in the proximal tibia, I think it's as high as 30 or 50% that will not fully reconstitute. So if you're looking to go back at a future date, you should definitely get an X-ray of a previously harvested site before you consider it for harvesting in the future. Or, if you will, backfill it with the least expensive and most effective material, which would be freeze-dried cancellous bone.
Gotcha. Okay, just a couple more questions. What key bone regeneration properties does COREX harvested graft have that competing harvesting systems and biologics or synthetics don't have?
Well, again, it goes back to minimal disturbance of the architecture, minimal disturbance of the cellular elements within the marrow. By minimally disturbing the architecture and the cellular elements, you're going to optimize the osteoconductive and osteoproliferative.
Okay. Okay. Great. So stop recording.